Hi, my name is Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, Washington. I'm here at the 2025 IMS meeting in Toronto. It's been a fantastic meeting so far. So one of the hottest changes at the IMS meeting, not final yet, but finally first discussed with the whole community here, is the new upcoming revisions to the response criteria for myeloma. All of you are well aware of this. Those of you who have seen me on this show before know that, for example, I hate, as much as our patients do, the idea of 24-hour urines being a part of response assessments. The idea is that response assessments are tremendously important, but also tremendously cumbersome, and we need to find a way to kind of navigate that path better. Response assessments are how we know how well treatment is working, basically. And there was a time where treatments for myeloma didn't work very well. And for example, there, even a 25% reduction in the M spike was considered a success. That used to be called a minimal response. Now, many of you listening are probably aware, for example, that our response criteria currently involve minimal response, partial response, which is a 50% reduction, VGPR, which is a very good partial response, a 90% reduction, and CR, complete response, which is basically what we typically use for the word remission. Complete response historically has required, for example, a 24-hour urine, which has been frustrating for patients. Historically, progressive disease, so when treatment's starting to not work, historically it's required two separate checks to show that the treatment's not working before moving on to something different. And historically, when patients had a measurable M spike at diagnosis, so an M spike is a serum paraprotein, etc., when patients had that, historically, you could only define relapse or progressive disease as when the M spike started to go back up. Some patients would have what we call light chain escape, where the M spike stays the same, but the light chains start to rise. So myeloma is mutated, and now the light chains are what's rising. And it would be so silly because by the book meaning the current IMWG response criteria, we couldn't say that they were relapsing. And in real life, obviously, it was time to move on to something different. Why does it matter? It matters in a couple of ways, mainly for our patients who are on clinical trials. They were being asked historically meaning like today still being asked. I'm already thinking ahead. Historically, they've been asked to provide 24-hour urine. Sometimes once a month, my patients on trials are being asked to provide urines. And secondly, for patients, when the treatment starts to not work again, we're kind of dragging on the inevitable, right? Which I think is sometimes not fair to the patient. If we know that another treatment that's off the trial is better, I think it's time to move on to something different. And so the IMWG, which I'm a part of, they had a meeting last year, and they're slowly trying to get through steps to standardize and update how responses are assessed. All the things I touched upon are basically going away. So 24-hour urines, which as some of you may know there's a lot of my research. I hate 24-hour urines once a month, will now be required probably only 2 to 3 times over a patient's lifetime, basically, to confirm that they're in remission and maybe at diagnosis, but not once a month for perpetuity. Very specifically, we're getting away from that. Light chain escape. So basically now on the flip side, whenever disease starts to come back up again, if 2 separate things are going up at the same time, for example, the M spike is rising and the light chains are rising, that will be sufficient to diagnose progressive disease, a relapse, time to move on to something different. And if any one of them starts to go up and confirmed goes up and up and up, that still counts. This idea of light chain escape, even when the M spike is stable but the light chains are rising, when that goes up, that will still be considered relapse. You may ask, who cares? This is all just doctors arguing with themselves. It is doctors arguing with themselves, but I think it has real-life consequences. One example I'll give is there was a study, the CANOVA study, looking at venetoclax dex versus pomalidomide dex. Some of you who may have myeloma cells with translocation 11-14 may have heard of venetoclax before. It does work quite well in this condition, but it's not approved for myeloma with T11-14, translocation 11-14. And they tried running the study of ven dex versus pom dex, and it didn't show by the book meaning the current IMWG response criteria, that venetoclax dex outperformed pomalidomide dex. Many reasons for it, but one of the reasons was because patients in the pom dex arm were coming off study before this relapse was confirmed. Because right now we require this confirmation, lots of hoops to jump through to confirm it. And because it wasn't confirmed, they weren't counted for the analysis. They participated in the study, which is amazing, but the results didn't count. And the curves between venetoclax and pomalidomide looked very similar by the book. They actually showed that overall survival favored the patients on venetoclax. They showed that if you looked at what the doctors thought, if you looked at the actual doctor-determined progression, length of remission, venetoclax won. By every other metric, venetoclax won. But because the book is so complicated, the trial was a negative trial. It didn't show us results. And as a result, that drug is not approved for myeloma treatment in the US today. So these kind of nuances have very important real-world consequences, and we can't update the response criteria every year because there'll be chaos if we do. Because we need to have a book, obviously, to determine how well is treatment working and make sure that every trial around the world, when they run this trial, relapse is defined the same way, remission is defined the same way, etc. But I think it's time to write a new chapter for that book. And that chapter is being written right now, presented today, and hopefully by the end of this year, it should be published. That doesn't mean that urines will be gone forever. It doesn't mean that everything I described will be immediately changed. It will take time for clinical trials to update themselves. But it's really nice to see that the reason we're even able to do this is because we have these new technologies, better drugs working for better and longer for our patients. So as the field progresses in terms of our treatments, our response criteria can advance as well.